a disease that affects the femoral epiphysis. And sequential changes take place in the epiphysis. A vascular insufficiency occurs, the cause is not known, and there is a suggestion that there's repeated infarction, which leads to clinical Perthes disease. Once that occurs, you see the clinical features and the radiological features of avascular necrosis of part or all of the epiphysis. Over a period of time, some resorption of the necrotic bone occurs by osteoclasts, and this leads on to collapse of the trabeculae and fragmentation of the epiphysis. Gradually, reparative processes take place. Woven bone gets laid down over the periphery of the epiphysis. This woven bone gets converted into lamellar bone, and the disease completely heals. Now, concomitantly, changes take place outside the femoral epiphysis, and in a sense, these are more important in terms of creating problems. When we look at the changes that take place in the epiphysis, you can then divide on plain radiographic methods itself the disease into different stages: the early part of the avascular necrosis, the latter part of the stage of avascular necrosis, the early part of fragmentation, the late part of fragmentation, the early part of reconstitution or regeneration, and the late part of reconstitution. The changes that take place outside the femoral epiphysis include synovitis, cartilage hypertrophy, and hypertrophy of the ligamentum teres. Now these, along with some muscle spasm, initiates femoral head extrusion. This progresses, and over a period of time, the extruded part of the epiphysis is subjected to weight-bearing stresses and muscular forces that pass across the acetabular margin, and this results in irreversible deformation of the femoral head. Some degree of remodeling may take place, but that's usually very little. You're left with residual deformity and incongruity, and over a period of time, you'll end up with degenerative arthritis. So the most important abnormality or problem that occurs is progressive extrusion of the femoral head, which goes on to irreversible deformation, as I mentioned. We have evidence to suggest that irreversible deformation of the femoral head occurs either at the late stage of fragmentation or very shortly thereafter. And therefore, you can now decide when you're going to do the preventive surgery. Clearly, when you know when deformation occurs, if you want to prevent the deformation, it becomes obvious that you've got to do the surgery prior to that. And therefore, preventive surgery can only be done from the onset of the disease till shortly after the early stage of fragmentation. You do remedial surgery from that stage on to the early stage of reconstitution. Why do I say that you can only go that far? Because once lamellar bone has replaced the deformed epiphysis, whatever you do is not going to change the shape of that epiphysis during the active stage of the disease. And so you then have to do salvage surgery to do something to correct the established deformation of the femoral head. So I would suggest that the intervention that we need to do should be soon after you demonstrate that there is some extrusion of the femoral head. As soon as you diagnose extrusion of the femoral head, you need to intervene. You need to reverse the extrusion of the femoral head. And the contained femoral head then is protected from the deforming forces of weight bearing and muscular contraction. The femoral head deformation is thereby prevented, and you get a spherical congruent femoral head. So when you think of surgical containment, there are other factors to take into consideration. One is the stage of the disease, as I mentioned now. You would consider containment if the child is in the stage of avascular necrosis on the early part of fragmentation, not after that. You would consider containment if extrusion is present in children who are under 12 years of age at the onset of the disease. And I'm giving that age cutoff because over the age of 12, they are adolescents. The disease behaves totally differently. Containment doesn't work. You need to restore the range of motion if you want to do containment. So if you do a containment procedure with a stiff hip, it doesn't work. Now coming to the age, I would suggest that if children over the age of 7 years, you'd consider containment all children with diagnosed Perthes disease, irrespective of whether there's extrusion or not. Why am I suggesting that? Because we have enough evidence to suggest that if you have a child whose onset is after 7 years, sooner or later the head will extrude, and surgery done prior to extrusion seems to have better results than if it's done later. Now, those of you who've happened to have read the recent issue of the Orthopedic Clinics of North America may note a disparity from what in this slide from what is written there. We have, after consensus from the different authors, suggested that we consider surgery for all children over the age of 8 years, because a lot of people in the West feel that that's the best cutoff point. Now, children in India seem to have a poorer prognosis. They've got an older age of onset, stiffer hips. We never see a cataract group 1. In other words, all of them have got half or more of the head involved, and they have poor prognostic factors. So we have found that it's probably wiser to operate at stage year 7 rather than 8. So you'll see a little disparity from what is published by me. So therefore, I'm suggesting that in children over the age of 7 years, you intervene even earlier, as soon as you diagnose it, because you know that the extrusion is going to occur sooner or later. And if they're under 7 years, wait till some extrusion occurs. You're justified in waiting. Not all of them will extrude. I would also consider trochanteric epiphysidesis in these older children, and we have shown that the probability of achieving a good effective trochanteric arrest is quite good till the age of 10 years. Right? This is contrary to early literature, which suggests that there's no use of doing a trochanteric epiphysidesis over the age of 8. We have shown that it works in at least 50% of patients in children up to the age of 10 years. And here's an example of a child who's had a varus derotation osteotomy and trochanteric epiphysidesis. And you can see here clearly the articular trochanteric distance, which Ashok referred to, is normal. What is the scope of remedial surgery? Remedial surgery, which is done at this stage, is mainly to try to give a chance of containment. It may or may not work. And more so, if there is this phenomenon which is referred to as hinge abduction, you would consider surgery. As far as salvage surgery is concerned, it's treatment for established deformity. Usually surgery is done after the disease heals completely, and it entails major type of reconstructive surgery in reshaping the femoral head, doing acetabular procedures, which are beyond the scope of the average pediatric orthopedic surgeon. Thank you very much. I go on to the next one. Yeah. Yeah, you're welcome. Have I stuck to time?
You have.
Oh, thank you, Matthew.
Thank you.
Thank you. Okay, we're going on to a practical session of trying to stage Perthes disease, and therefore it necessarily has to be interactive. The entire basis of what I mentioned in my previous talk revolves around being able to stage the disease. How far has the disease evolved? And I'm going through this in a little detail. Can I have these lights dimmed a bit, please? In stage 1A, that is the early part of avascular necrosis, the epiphysis avascular appears dense. There is no loss of height of the epiphysis when you compare it to the normal side. In stage 1B, there's loss of height of the dense epiphysis. The epiphysis is in one piece on the AP and the lateral views. I've taken the liberty of only showing the AP views to avoid confusion. But to decide which stage it is, it's imperative that you take AP and lateral views. Okay? The frog lateral view or the Lowenstein view. But here I'm only showing the AP to avoid confusion. Stage 1B, you can see that very clearly. It's sclerotic, and if you compare with the normal side, there's loss of height of the epiphysis. In stage 2A, you find that there is a loss, one fissure has appeared on the, sorry.
Forward.
Yeah, Yeah, one fissure perpendicular to the articular surface. Now, some people confuse this with the subchondral fracture line. This is not a subchondral fracture line. The subchondral fracture line is something that you see in the first stage of the disease, and it is parallel to the articular surface. This is perpendicular to it. So it's a fissure that has appeared. If there is one or two fissures at the most in the AP and lateral view together, you say it's the early stage of fragmentation. Here you can see the epiphysis is frankly fragmentous. It's the second stage, or stage 2B. There's collapse, and this is when the maximal collapse occurs. This is when the maximum extrusion occurs. This is the worst part of the disease. Now you can see, if you're lucky, very, very early new bone there. It's a little fluffy new bone. That's the very earliest part of stage 3A. That's woven bone. The texture is not like normal bone. Another example, you can see a little bone there. Not normal texture as compared to the acetabulum or the metaphysis. You can see that. And that's a necrotic part lying under it. This new bone starts from the periphery of the epiphysis. Now you can see that's replaced by lamellar bone. The texture here is the same as texture there, and is covered at least 1/3 of the circumference of the femoral epiphysis. And stage 4, there's no avascular bone left behind. Okay? This duration to pass from stage 1 to healing is anywhere between 2 to 4 years. Right? Now comes the interactive exercise. I'm going to ask Dr. Matthew to select someone to answer this question. What stage of the disease is this, based on your attentive listening?
Yeah.
Yes, sir. Would you tell me what stage this is?
So stage of early fragmentation.
Where is the fragmentation?
Early fissuring is seen in the...
Well, would you like to give a neighbor a try? Pass it to the right.
I'll guess stage 1, the subchondral
No,
collapse.
It doesn't. Look a little more clearly. This is stage 3B, and why do we say so? There's lamellar bone covering the lateral third of the epiphysis, right? 1/3. And there is some remnant of avascular bone. So you must be able to appreciate that there is a little avascular bone there. This is new bone that has formed round from the periphery, and that's the remnant of the avascular bone. So this is not fragmentation or the early stage. This is well advanced stage 3B. Okay? Now who's the next victim?
Stage 3A.
Can you see new bone on the periphery?
No.
Can you see a necrotic segment?
No.
The entire epiphysis seems sclerotic, but you can't see a new bone covering the necrotic part. Right? So what you see here, this is 2A. You can see one fissure in the epiphysis. Right? Interestingly, it is this fissure that separates what Herring calls a lateral pillar. This is stage 2A. Next victim, please. Take a guess. You've got a 1 in 5 being chance of being correct.
So 3A.
Sorry?
3A.
That's a good guess, but it's 1A. There's no loss of height of the epiphysis, there's no fragmentation, there's no new bone, there's no necrotic area seen elsewhere. Okay? Right, we're doing exceedingly well. Now, some victim.
There is a loss of height, so it is 2B. There is fragmentation.
Yes.
And
Is
a
it
loss.
fragmentation or late?
It's late fragmentation.
Fantastic. That is 2B. Right? So 3 fissures are visible. It's late fragmentation. Very. Who would like to take this?
Sir, there is a loss of height is there, sir, with fragmentation and new bone formation is there. So
There is new bone formation, I agree.
And
So is it
is-
early stage of reconstitution or late?
so it